Hi there, my name is Joan Harris and I'm an instructor for the ACCN program. This PowerPoint will review the information from Module 2 on analgesics for the critically ill patient. We'll start off defining a few important terms and then discuss both opioid and non-opioid analgesics. The terms that we will define are pain, anxiety, agitation, and delirium. I'll offer two definitions of pain. The first is from your course textbook, Brenner and Stevens, Pharmacology. Pain is an unpleasant sensory and emotional experience that serves to alert an individual to actual or potential tissue damage. A second by McCaffrey and Beebe from their book on pain, Clinical Manual for Nursing Practice, slightly more prosaic. Pain is whatever the person experiencing it says it is and occurs when that person says it does. This is meant to be a little bit more encompassing of the subjective aspect of pain. Whatever your definition, pain has long-acting negative effects if left untreated. For example, pain increases O2 consumption. It increases the release of stress hormones, as well as it causes sympathetic stimulation. It also interferes with immune functioning, can cause hypercoagulability, and decreases gastrointestinal motility. Pain and anxiety often go together, and anxiety has been shown to increase the perception of pain. Anxiety is a prolonged state of apprehension in response to real or perceived fear. Again, as with pain, we can see increase in sympathetic nerve stimulation. We see an increase in oxygen consumption. Actually also can potentially contribute to dysrhythmias, can alter sleep patterns, and if allowed to be untreated, can progress to agitation and delirium. If pain is left untreated, both agitation and delirium can result. Agitation is excessive, usually non-purposeful motor activity, and is often accompanied by anxiety, panic, delusions, hallucinations, and flights of thought. Agitation also increases muscle activity, sympathetic stimulation, and there is an increased risk of injury. Delirium has come to the forefront of our awareness as nurses in the ICU because of its prevalence and long-term sequelae. Delirium is an acute disturbance in mental status characterized by inattention, disorganized thinking, altered and/or fluctuating level of consciousness. It results from an underlying pathophysiological condition, is preventable, and in most cases reversible. For further information on delirium, please review the delirium PowerPoint you will find later in this course website. Now we will begin our discussion on analgesics, starting with opioids. Opioids represent a large portion of the medications we use in the ICU to treat pain. A common term for opioid used to be narcotic agents, but as this term also refers to illegal drugs such as cocaine, we will not use it with respect to this group of analgesics. There are both natural and synthetic derivatives of opioids that come from the opium poppy. These derivatives bind to the same receptors as endogenous opioids such as enkephalins and endorphins. The opioid receptors are found throughout the brain and spinal cord, and when stimulated, they alter the response to painful stimuli. As seen in this diagram, opioids have an agonist effect on the opioid receptors, primarily mu and kappa, found on the primary afferent neurons, which inhibit release of pain transmitters, as seen by the number 1 here. They also have an antagonist effect on the postsynaptic receptors of the spinal thalamic tract neurons, which inhibits the ascending pain transmission, as seen in number 2. And finally, opioids have an agonist effect within the brain, which enhances descending inhibitory pain messages, as seen in number 3. In this way, opioids mimic the effects of endogenous opioids. Morphine is considered the gold standard to which all other opioids are compared. Several different opioids will be discussed, and each has slightly different properties based on the receptors they stimulate. Along with the analgesic properties, morphine also potentiates the effects of sedatives and hypnotics, causes the release of histamines, which can lead to hypotension, bronchoconstriction, erythema, and pruritus, and can cause respiratory depression. Despite these adverse effects, it is widely used for acute pain because it is inexpensive and can be given via multiple routes. The most common dosing route in the ICU is IV, where the onset for morphine is about 5 minutes, it peaks in 20, and the duration is 4 to 5 hours. It's important, regardless of which analgesic you're using, to consider the route, dosage, and interval when treating critically ill patients' pain. Fentanyl is another commonly used analgesic in the ICU. It's a synthetic opioid which primarily stimulates the mu receptors. It is very fast acting and very potent, so its onset is 1 to 2 minutes with a peak action within 3 to 5 minutes. And the duration of action is about half an hour to an hour. And 0.1 milligrams or 100 mics of fentanyl is equivalent to 10 milligrams of morphine. MEPERIDINE is also synthetic and has analgesic and sedative effects. We don't see it as frequently in the ICU anymore because of its potential toxicity and the superiority of other opioids. Codeine also is used less frequently in the ICU due to its low affinity for the opioid receptors, causing less of an analgesic effect. It is used primarily as a cough suppressant or for mild to moderate pain, often combined with Tylenol. Codeine is only given through the oral route, as if it's given IV, it produces a strong histamine release. If a patient receives too much opioid, naloxone, also known as Narcan, can be given to reverse the effect. It acts by displacing morphine from the opioid receptors. It acts rapidly and is short-acting, therefore small incremental doses are generally ordered, and it may be required periodically until the opioid is fully metabolized and excreted. Although opioids are the mainstay for the treatment of pain in the ICU, there is still a place for non-opioid analgesics. Non-steroidal anti-inflammatory drugs, or NSAIDs, inhibit the synthesis and release of prostaglandins by inhibition of cyclooxygenase, as you can see with number 1 on the chart here. Prostaglandins are involved in sensitizing pain receptors and inflammation, maintaining gastric mucosal lining, and have a role in the production of thromboxane, which causes the aggregation of platelets. These agents are typically used for the relief of mild to moderate pain and may be used in combination with other opioids. Because of the reduction in prostaglandins, NSAIDs have 4 major effects: analgesic, antipyretic, anti-inflammatory, and antiplatelet. Different NSAIDs will each have a slightly different combination of these effects and adverse effects. Adverse effects, again related to the inhibition of prostaglandins as well as decreased thromboxane, include prolonged bleeding time, gastrointestinal ulceration, and decreased renal function. Some common examples are acetylsalicylic acid, or ASA, and ibuprofen. The mechanism of action of acetaminophen is less well understood, but it is believed to provide more selective inhibition of prostaglandins with greater effect in the CNS than peripherally. Because of this, it has less anti-inflammatory properties and does not inhibit platelet aggregation, which makes it less disruptive to the gastric mucosa and kidneys, and it does not promote bleeding. Acetaminophen has both analgesic and antipyretic effects, but because it has no effect on inflammation or coagulation, it is not considered an NSAID. Acetaminophen is indicated for the relief of mild to moderate pain and may be used in combination with other opioids. In sufficient quantities, the enzyme that metabolizes acetaminophen is saturated, and a toxic metabolite is produced instead. This metabolite is toxic to the liver, so in cases of overdose or in cases of a larger dose taken chronically, the patient is at risk for hepatic toxicity. So that concludes our presentation on analgesia. Please refer to the other presentations for Module 2 on sedation and delirium. If you have any questions regarding the material in this presentation or your course materials, please contact your instructor.